Hello and welcome to a new episode of the Under Pressure podcast. I'm Dr. Jonathan Sacchio and I'm proud to be your host. Before introducing our guest for today, it's important to specify that this podcast has been supported by Myo1, a Canadian medical device manufacturer. Please refer to the show notes for further information, and you can be in touch with us at underpressure@nextsense.com. That's underpressure@nxtsens.com to ask any questions that we shall endeavor to answer. So today, I'm delighted to welcome Peter Giannoudis, who's Professor and Chair of Trauma and Orthopaedics at the University of Leeds here in the United Kingdom. I have to take a deep breath when I say this because with over 800 peer-reviewed publications, I actually thought that I'd been quite productive in my surgical career, but I'm a neophyte in comparison. But 800 publications, Peter is a leader in orthopedic trauma research and clinical practice. And we'll be discussing his latest study on risk factors for acute compartment syndrome, ACS, insights into treating open fractures, acute bone loss, and the impact of compartment syndrome in athletes. Because you see, Peter is also a very keen runner. So without further ado, Professor Peter Giannoudis, welcome to the Under Pressure podcast.
Thank you very much, Jonathan. It's a great pleasure to interact with you and obviously to share our thoughts and opinions about all these interesting clinical topics that you highlighted previously.
Yeah, as I was saying to you, Peter, I trained in general surgery and did colorectal endoscopy. And although I had a fascination with orthopedics earlier in my career, and I flirted with becoming an orthopedic surgeon. In fact, I did an elective with a guy named Bill Enneking in Florida, who's, I believe, quite a famous gentleman. But he was also a very scary guy. So, but I mentioned that you were a runner, and you told me that you'd done your Achilles tendon and have recently had it repaired. How's that going for you?
Well, for those that they are familiar with Achilles tendon injuries, it's a long process. Mine, it was not an acute repair, it was a delayed repair, and unfortunately I ended up having a gap of about 2 centimeters. So primary end-to-end anastomosis was not the way to go forwards because the edges were also deemed to be a bit avascular.
Yeah.
So other means of reconstruction were necessary to address my personal problem, and in that respect I ended up having a hamstring graft to my Achilles tendon. That was almost 7 months ago. It's a slow process. I think I'm improving with time. Obviously, patience, rehabilitation, belief, and positivity are key to any means of um, getting back to normality in terms of the activities that you enjoyed prior to the injury on a personal basis. So things are moving the right direction. As I said, it's a slow process. My uh, target in terms of coming back to recreational activities is the 12-month time point. So I guess after February next year, I should be doing a bit more, and things will look brighter to what they look right now.
I sincerely hope so. I was doing some reading recently about PRP, platelet-rich plasma. It's being vaunted for everything from alopecia to Lord knows what. Does it play? Are people using it for Achilles repairs?
There are a number of studies have shown that it can improve the healing process and possibly can accelerate the return to sport. Obviously, in my case, as a case study, I cannot give you any kind of personal feedback because I was not exposed to this specific treatment modality. But I think each case should be examined on an individual basis. In my clinics, when I see patients with Achilles tendinopathies. Some of them they are very positive following the injection in terms of recovery. Some others they haven't seen much difference, and this is why I say it can help. But I my personal experience is that not everyone has had the same kind of a positive experience
Yeah.
following this type of treatment.
Yeah, yeah. Well, I think the jury is still out and on it for many things. And so, changing subject a bit, Peter, you've first of all, I wish you a speedy recovery and that you can
Thank
very
you.
soon be running across the glorious Yorkshire moors. For people in America that are listening who haven't visited, they often come to. I'm a Londoner, but the Yorkshire countryside is absolutely stunning. And so, anyone listening overseas, put it on your to-do list. So, Peter, you've had an illustrious career in orthopedic trauma, leadership positions across major organizations. And as I said, you've published, I think 800 constitutes prolifically. Can you share what first inspired your journey into orthopedic trauma and how your role, how your job, how your work has changed over time?
Where to start and where to finish? Well, having been, let's say, I would dare to use this word, an elite athlete. And I say an elite athlete because when I was 18 years of age, I ran the marathon in 2 hours, 23 minutes, and that was pretty good at that time point. And in fact, I was a member of the Greek Olympic team in 1984. So, having had this kind of career in running, when I finished medical school, my inspiration was to become a sports medicine doctor and look after athletes like myself, having gone through injuries and knowing what is like not to be able to perform because of any kind of an injury. So I wanted to follow that career path and help elite athletes knowing what is like to be one and what is like to be suffering with injuries. Nonetheless, when I started my orthopedic training, uh, my research then it was quite unique and advanced in terms of the timing when I did my PhD, and I focus on the immune response to trauma. It was quite uh, unique then because it was a new field to be explored. So I started looking into molecular mediators, adhesion molecules, polymorphonuclear leukocytes, interactions with endothelium. And as a result of this, I started shifting my interest from sports medicine to acute trauma. And as part of my thesis and research, um, I, I used to go to the scene of the accident or be the first one to go to the A&E department in the resuscitation room to meet patients with multiple injuries, with severe injuries, to take the first blood after the injury, to assess the any correlation that could be present between injury severity and immune response to trauma. So gradually, because of my research interest and started loving the sequelae and the challenge to deal with trauma patients with multiple injuries, I became an orthopedic trauma surgeon, and since then, all my career has been focused in this discipline of orthopedics.
So you've chaired the AO Trauma Global Research Commission, been a leader in trauma research. There have been many innovations during your career, and shifts in trauma care, certainly in resuscitation and so on and so forth. But what do you think have been the major shifts, particularly in managing complex fractures, that stand out for you?
That's a very interesting question, Jonathan. And as you can appreciate, obviously being a general surgeon, with all the research that has been carried out the past 20, 30 years, we've learned more about how the bone heals. We learn more about the importance of the blood supply, how we should respect the soft tissue envelope surrounding the bone, how we can minimize the surgical insult to the bone as a tissue, and how to prevent complications. And the most important complications for the bone is the development of infection and the development of non-union. So over the years, appreciating how choosing the appropriate approach to stabilize a fracture, how performing minimal invasive surgery, how to reduce the fracture with less invasive maneuvers, obviously helped a lot to minimize these complications. And that led to the development of new implants being inserted with a minimal invasive approach. Obviously, we learn more about what are the important molecules for fracture healing and how we have appreciated the uh, importance of inductive molecules, growth factors, mesenchymal stem cells, scaffolds, combination of all the above, the impact of mechanical stability, the how the surgeon can influence how a fracture can heal by applying the concept of relative stability and absolute stability. All these uh, parameters that I highlighted have contributed immensely to how we manage fractures nowadays and how we can get the patient to heal in a timely fashion without the need of reoperations and obviously development of complications that can have a major burden to the patient, the family, and the healthcare system. So, all these important knowledge that we acquired over the years as a result to our understanding of the pathophysiology of fracture healing and trauma have contributed to what we do nowadays in every form of the clinical pathway, every step of the clinical pathway of the patients.
Yeah. And of course, you mentioned infection with the rise of antibiotic resistance, the importance for all of us to be responsible stewards of antibiotics is never more so because in your field, an infection can be absolutely disastrous for the patient.
Well, if it is not well controlled and become a chronic problem like osteomyelitis, as we call, and then that can affect obviously the whole extremity, uh, and particularly in frail patient cohorts like elderly patients with comorbidities, diabetes, peripheral vascular disease. If we cannot control that, then we know that the end of the road to treat it, unfortunately, is amputation, loss of the limb, and obviously prevention and knowing what to avoid to allow this to evolve from a cellulitis, from an abscess, to a full-blown picture, clinical entity of stomatitis. It is very, very important.
Yeah, yeah. So you recently published a study in International Orthopaedics entitled risk factors for acute compartment syndrome in 1,147 diaphyseal tibial fractures. And it highlighted the key risk factors for the development of ACS, acute compartment syndrome. Can you summarize the most significant findings, particularly regarding the role of fracture patterns, patient age, surgical methods in the development of ACS, and any other important findings from that study?
Yeah, this is a large study. We studied 1,147 uh, patients, and what we observed was, first of all, that the incidence of acute compartment syndrome was 5.1%. So that was about 58 cases out of the almost 1,150 patients that we analyzed. Uh, the focus was tibial compartment syndrome. Tibia, as we know, is an area with the highest, an anatomical site with the highest incidence of acute compartment syndrome, 36% if we look into the overall incidence of compartment syndrome. And what we observed was that young patients, uh, male, presented with a multifragmented diaphyseal tibial fracture pattern, and we're talking about the AO classification of 42C. 42 refers to the tibial anatomical sites, with a high BMI. They all showed to be these parameters an increased risk of developing compartment syndrome. Of course, we analyze the incidence prior to surgery and after surgery. The vast majority of these patients, 51 out of 58, were diagnosed with compartment syndrome prior to surgery. And the key point to take out of this study is that, of course, you can use the clinical diagnosis, the 6P as we call it, or measurement of the intracompartmental pressures to make the diagnosis. But when the patient presents, young patients, the vast majority of them after road traffic accidents, motorcyclists, that means high energy trauma. So it's a big kind of impact. And that also is supported by the multifragmentary fracture pattern to get this type of fracture with different kind of fragments around the diaphysis of the tibia. You need a big impact to see this type of fracture. And with this type of injury mechanism, obviously the fracture line can extend from the diaphysis as a fissure to the knee joint. That was another observation that we found in this study, Jonathan. And this has to be um, kept in mind when you manage these patients, when they come through your clinic, to remember that compartment syndrome is a risk, it can happen, and you must keep a very close monitoring in these patients.
Certainly. So, Peter, um, the the fact that males were more likely is hardly a surprise because we as we as a sex tend to do silly things with higher frequency than females. But what about the role of body mass index? Can you explain that? Because I might have misunderstood.
No, indeed, it was a risk factor when we did the analysis. And I guess the question is, why do
You
we
mean to have a high or a low BMI?
a high BMI, patients with a high BMI had a greater risk of developing compartment syndrome. And I guess that comes down to the risk of bleeding. When you've got a higher BMI, and the muscle bulk and the fat tissue around tibia, then the risk of bleeding is higher.
Yeah.
And obviously, we one can also extrapolate that the fascia and the different compartment syndromes, they possibly they have less elasticity or they are thicker, and this is why we see this phenomenon in these patients.
Interesting. There was also an association with specific risk with intramedullary nail fixation. Do I remember that correctly?
That's correct, and that was the finding. So in 7 patients, the compartment syndrome was after surgery, and in all of them was after intramedullary nailing of the tibia, rim intramedullary nailing. So that means that you need to have a high index of suspicion in patients that their tibia has been stabilized with rimmed IM nailing. Why is that? Of course, first of all, you shouldn't be using a tourniquet because of the blood flow afterwards and the increased pressure that is developed. When we rim the tibia, what happens is we destroy the endosteal blood supply, and that means that afterwards all the blood supply, because the nutrient vessel is destroyed, it goes to the outside of the tibia to the periosteum, and that can increase the risk of bleeding and the risk of the pressure within the 4 compartments of the tibia. And therefore, you need to keep that in mind, not to miss it.
Right. So, Peter, given these observations, how should trauma teams interpret this and adjust their management pre and post operatively for, for nail patients? Higher risk profiles,
Of
I
course,
guess.
of course. Well, first of all, what I would like to say to make it clear, uh, compartment syndrome is a clinical emergency. We all know that. And our objective, it doesn't matter where you work, whether it's a university hospital, a district general hospital, a private clinic, we always must think about this complication. Because unless you think about it, unless you look for it, you will miss it. And we all know compartment syndrome is the most common reason of litigation, at least in the orthopedic trauma discipline. When you miss it, you cannot defend it. There is no excuse. So we need to start from that kind of position. So any patient with lower extremity injury, particularly the tibia, but we should not forget the femur, the upper extremity, the foot, you name it. It can take place anywhere in the human body. Abdominal compartment, for example, going to your own kind of specialty, Jonathan. So always,
Yep.
whenever we have patients following high energy trauma, crash injuries, elective procedures where the limb has been placed in a position for a long period of time, lithotomy position, for instance, anything which
Yep.
would be associated with a risk factor should raise an alarm. As simple as that. Now, having said that,
Yep.
if we go to the study from our institution, what do we say? Young patients following road traffic accidents, patients with high BMI, uh, patients with multifragmentary closed tibial diaphyseal fractures, patients following intramedullary nailing. These are buzzwords that should alert the clinician, think and look for compartment syndrome. If you do that, you are not going to miss it. This is the message. And also, um, don't forget open fractures. We look for an association. It didn't reach statistical significance, but even any open fracture, tibial fracture, can lead to compartment syndrome. So whenever you explore open fractures, whenever you do debridement, uh, think about doing fasciotomies in the compartments where you are there, you are exploring them, and you try to debride them. It's not going to harm you. Reduce the risk. So this is my message. Think about it. Any patient can develop compartment syndrome. If you miss it year 2024, for me, it's poor practice, poor management. You don't read the textbooks, you don't read the papers, you don't follow the guidelines, and you cannot defend yourself.
Yeah. In fact, there are many guidelines, aren't there, about in the United States and elsewhere about how often you should see a patient with a possible compartment syndrome, and the implications are everything from some clawed toes to limb loss and even loss of life. It's a profound complication. In fact, the thing that got me involved in this whole space, what fascinated me, was as a surgeon who has dealt with abdominal trauma, perforated diverticulitis, and you're dealing with possible intra-abdominal hypertension compartment syndrome. It's a nightmare. And in our world, those patients can end up in the ICU with a laparostomy for weeks and weeks. The costs are profound, way beyond the human costs. So your point is very, very well made. So given your comments about high energy trauma, challenging to manage, you also mentioned the risks of infection and obviously compartment syndrome. So, what are some of the management paradigms that you would recommend um, open fractures to reduce the risk of ACS and improve overall outcomes beyond what you've already said, of course?
Yeah, so when we talk about open fractures, there is a spectrum. There are different classifications we can use, and let's focus about the most severe ones, the Gastillo type 3B and C. The B, by default, they require soft tissue reconstruction, like a free tissue transfer, a flap, whether it's rotational or a latissimus dorsi or a gracilis. And the type C, obviously, is the ones that they are associated with a vascular injury as well. So the management of these severe injuries has been evolved over a period of time. We learn more and more about the importance of the threshold of soft tissues not to start going the process of necrosis. We are all know about the 6 hour time point beyond which necrosis is permanent. So if a limb, an open fracture, comes with a vascular injury, we need to operate. We need to address the vascular lesion as soon as possible. Maybe proceed with a shunt, revascularize the limb, minimize the risk of ischemia and necrosis, then proceed with repair of the vascular lesion, uh, either temporarily or definitive stabilization, pending on the timing of intervention, the skill set of the surgeon, the institution, etc. Do the fasciotomies, allow the soft tissues to become again vascularized, and then like that we minimize the sequelae of this dreadful situation. For instance, hypoxia leads to death soft tissues, the muscle. Um, Avascular tissues lead to the development of infection. Infection leads to the development of osteomyelitis. Osteomyelitis leads to the development of bone debridement, etc., etc., etc. A vicious cycle. And then, if we lose control of the situation, obviously, never mind the degree of morbidity, but we should not underestimate the risk of loss of the limb, amputation. So, following the principles of management, debride, irrigate, revascularize, stabilize, soft tissue reconstruction, minimize the risk of infection, and then, if needed, proceed with the management of, let's say, non-union, deal with the problem of reintervention to get the bone to heal and restore the function of the affected extremity. So it's a process where we need to follow all the necessary steps, follow the guidelines to minimize the risk of morbidity and, of course, loss of the limb. And in the severe kind of situations, particularly in the frail elderly, also minimize the risk of mortality. So this is a process where we need to develop the management of these patients to ensure that the outcome will be good, will be positive, and we're not going to go into this vicious cycle of reinterventions and more interventions. I've seen patients with 16, 17, 18 operations following these sort of injuries, and we need to make sure that no patient will get into that kind of category of operation and another operation and another operation, which it's dreadful uh, to see and to meet these patients in your clinic because the principles and the guidelines were not followed.
Yeah. In fact, there was a recent, you mentioned litigation earlier. There was a case in America, I think about a year or so ago, in Minnesota, of a young man who had a missed compartment syndrome diagnosis after a tibial fracture. And the settlement was $111 million, which bankrupted a number of doctors. And the poor man had, I think it was, I could be wrong, but I think it was about 22 operations for all the sequelae. So I think the message that I'm getting is, I fly airplanes from an avocation, and there's an expression in aviation that we fly ahead of the aeroplane. You're constantly asking the question, what's the worst possible thing that could happen now? And what would I do about it? And what do I do to prevent that from happening? And a lot of it is about data acquisition, so that you're making sure that you're not running out of fuel, you're not flying into a thunderstorm, you're not flying into terrain, or so on and so forth. Oh, and again, you mentioned the skill of the surgeon, the skill of the pilot. You're not putting yourself in a situation that you can't manage if things go pear-shaped. So I'd like to come on to another complication, acute bone loss, often seen in severe trauma cases. What are some of the most promising strategies that either you or others are researching or implementing to address bone loss in complex fractures?
This is again a very challenging clinical situation, clinical entity, because regenerating bone loss is not straightforward. You need to look to the location where the bone loss is missing. You need to look into the previous history, what happened up to now, to understand um, what has taken place. You need to look into the patient profile and the patient comorbidities. You need to look into the psychological profile of the patient, because all these clinical problems, they have a spectrum. It's different to restore a 3 centimeter bone loss compared to 20 centimeter bone loss. We are talking about a very long clinical journey to restore that bone that is missing. There are different techniques. Traditionally, distraction osteogenesis, bone transport, as we call it, has been the workhorse of restoring bone defects. However, this treatment modality will now requires a lot of patient compliance, is associated with a lot of um, procedures, broken wires, infected wires, problems with the regenerates, docking site problems. So a lot of these patients may undergo 4, 5, 6, 7 operations to actually get to the end of the road in terms of completion of the treatment. So it's a clinical treatment that needs a lot of patience, um, and it has been shown that a lot of these patients cannot tolerate frames more than 6 to 9 months. But when we've got a bone defect 20 centimeters, we're talking about treatment maybe 2 years. So it's an impact that the patient has to be informed in terms of his mental state, the family, the trips to hospital, the complications, the step backwards and forwards, etc. Moving on from there, uh, other techniques that one can utilize, it's the so-called induced membrane technique or muscular technique, which is a two-stage approach. You implant a cement spacer in the area of the bone loss.
Peter, can you
Yeah.
hear me?
Yes.
The signal fragmented when you were saying the name of the technique, and I heard you say these, and then I didn't hear what the technique was because it all fragmented.
No, it is another technique which has been popularized lately is the induced membrane technique, or so-called the Masculet technique. And this is as a appreciation to Professor Alain Masculet from Paris, that invented, is considered as the father of this technique. Is a two-stage technique where we insert a cement spacer, a PMMA, that creates a foreign body reaction and membrane is being formed. This membrane, we first named it from Leeds with the research we've done as a induced periosteum, because it resembles the normal periosteum, and it allows the surgeon to go back, remove the cement spacer, graft the defect area. Even defects up to 25 centimeters can be managed successfully, and this membrane basically brings vascularity to the graft that you implant. It can release inductive molecules, growth factors. It also contains progenitor cells, and like that, the bone you implant over there, it can, over a period of time, can become part of the host. It acts as a bridge and basically builds the bone that is missing, provides continuity, and like that, we can heal the defect successfully. And a number of publications have highlighted the success of this technique, including our results from our institution. And then, of course, to very, very quickly to address this question, Jonathan, other techniques include free fibular vascularized graft, titanium cages, uh, transfer of the fibula from laterally to medially in the tibia where is the defect. And these are some of the options that one can be considered to address this difficult clinical problem, restoring the bone that is missing, the so-called bone defect treatment.
Yeah, it's astonishing the role that technology has played and the inventiveness of people in your specialty, you and many of your colleagues, and how things have changed when I was first exposed to orthopedics. So keep at it. So I want to change tack a little bit. You're a runner. You mentioned that you were a very serious runner. By the way, saying that someone finishes a marathon in 2 hours and 43 minutes, I think you said. I think the sentence finished a marathon, was it 2 hours 43?
2 hours
Yeah,
23. Uh, that was
20. Oh my!
quite good in
I'm
1980, you know.
Uh, Peter, the term finishing a marathon in any time, as far as I'm concerned, people who can do that are, they're superheroes. I'm very impressed. I got into long distance hiking a few years back, and I started developing a strange leg pain that I'd never experienced before. And I know acute compartment syndrome is, as you've discussed, sequel for tibial fractures, forearm, the foot, after being in lithotomy, revascularization, ECMO. I know, but there's also this other form of um, compartment syndrome, sort
A
of a
chronic
chronic
compartment.
exertional.
Yeah.
Yeah, which I wondered maybe I have it. So, how common is it? What's the role that pressure monitoring, continuous pressure monitoring, might play in diagnosing it? And how does it relate to the mechanisms that you see in trauma patients? And has your interest in running influenced your understanding of lower limb ACS? And can I come and see you about my legs, please?
Of course. So look, this is also a very interesting subject. Um, I have to say that in my clinic, and I see a lot of patients on an annual basis, I might see 2, 3 patients with chronic exertional compartment syndrome. So is not as common as the acute compartment syndrome. But again, we need to appreciate that this entity exists, because I've seen patients that they have been seen by other professionals, and unfortunately they missed to make the correlation that this is the problem, and not, they were looking for tumors doing MRI scans, they were looking for periostitis, they're looking for bone bruising, for a fracture. And again, we must think about this clinical entity, otherwise we are not going to make the diagnosis. So what happens? Normally, in these individuals, I see that in. I can't say that is more in males than females. I think in my practice there is an equal distribution between male and females. Normally, the ones that I see, they complain about symptoms. Let's say if they're not keen runners, after walking of an hour and a half, they get that anterior tibial pain. They complain about tightness and stiffness. They have to stop. The pain can become quite intense. They report that their calf becomes very, very tight, and they have to stop to get some relief, some comfort from this pressure like effect, and sometimes tingling or paresthesia over the anterior aspect of their foot. And how do you make the diagnosis of? Obviously, history is very important. Of course, you need to exclude anything sinister. And then normally what I do, I get them to walk around on, or if it's a run around about around 10 minutes around my clinic, and then they come back as soon as they feel that discomfort, and then I measure the intracompartmental pressures as soon as they come back to the clinic. And you can make the diagnosis very easily if you do that. Listen to the patient, think about it. You can measure the pressures after a short period of exercise, and you can make the diagnosis.
Yeah. Well, I know that all the sinister thoughts went through my head as well, but then I reassured myself not to be such a hypochondriac. It's fascinating, and I'm sure we should watch this space. So, Peter, looking ahead, what are the next big steps in orthopedic trauma research, and how can clinicians, researchers, and the medical device industry, like my one, work together collaboratively to advance the field and improve patient care? The kind of work that I've done working with companies, I don't think companies can produce technologies that we don't need. We need to tell them, this is a clinical problem. Can you help me solve it? So, what are your thoughts? What are the next big steps in orthopedic trauma research?
So, Jonathan, you hit the nail on the head. There has to be an ongoing interaction between industry and clinicians. That's the only way that you can, first of all, become familiar with what is out there, because a lot of times we are so much absorbed and preoccupied with our work treating patients, and we do not follow all the developments that are happening, maybe not in our field, but there is overlap of this technology being transferred to our institutions, to our practice. So identifying key clinical gaps. What is the problem that we have not found a solution? What else is out there in terms, for instance, of diagnostics, in terms of treatment, in terms of rehabilitation, you name it. For me, questioning everything and whether we can do better is very, very important to continue this roadmap of improvement in patient care, whether it's the diagnosis, whether it's implants, whether it's developing new protocols, reducing morbidity, reducing mortality, everything. It's an opportunity for improvement. So where do I see a lot of developments happening? First of all, infection continues to be a major problem for us. Okay, prevention always is the best cure in medicine, and we are doing everything. MRSA decolonization, good theater environment, um, following all the guidelines, etc. We are doing all these things, but still, uh, it's happening. It's happening even in situations where we never thought it's going to happen. So, developing other preventative strategies, for instance, coating of implants, having developing antibiotics which can deal with this antibiotic resistance, that we are running out of treatment options of very difficult bugs to treat, to kill. It's very, very important. Developing approaches where we can diagnose the problem really, really quickly. For instance, if we have a bone infection which is evolving and we're not aware, because the immune system, our shield, is suppressing everything, If we can identify early this, then we can minimize the amount of bone that is affected and it has to be excised. Or when I operate on a patient with osteomyelitis,
Yes.
normally, I have to go microscopically where I can see bone that is bleeding, and I can stop there as a margin, like doing excision of tumor. If I have something which he
Yes.
can tells me
Yeah.
the limit
So
between infection and non-infection, that will be great.
yeah, absolutely. Well, I mean, the technology that's found its way into oncology, cancer surgery, so that we can identify margins
Yeah.
utilizing markers and special light and such like. Well, I think it's fair to say that if there's going to be an innovation in orthopedics in trauma, you're going to be involved. And it's been absolute joy talking to you, Peter. Sadly, that's all we've got time for today. So it just remains for me to say a huge thank you to Professor Peter Giannoudis for joining us today, for sharing your work, for everything you've done and will continue to do for your patients, and also a big hope for a speedy recovery. Thank you, Peter.
Thank you very much as well, Jonathan. And I hope we're going to have another opportunity, part two, one day, to continue our interesting conversation and to catch up with the latest developments. So thank you very much for the invitation. And I hope our paths will cross again in the near future. What can I say? Thank you.
Thank you, Peter. I'm actually going to be up in Leeds in the next month or so, and I'll drop you a line and we can get together, which would be lovely. So,
Please let's meet together.
So I just want to say to our audience, thanks so much for taking the time out of your busy day to listen and demonstrate a desire to see the best care for your patients. Please share this with your colleagues, post on social media, write to us at underpressure@nxtscns.com, underpressure@nxtscns.com, with comments, questions, or suggestions for other topics for this podcast. And thanks also to Maya One for supporting the podcast. And all that remains for me, your host, Jonathan Sakia, is to say, please, everyone, stay safe, stay well, stay curious. Bye for now.